Now we will invite Prof Chng for more information. Okay, Prof Chng will share on his current research to improve the patient's outcome and personalizing treatment for patients. Welcome, Prof Chng.
Thank you very much, Helen, and it's always very nice to see so many of you here. I think I've been doing this for 7 years, right from the beginning. We started this even before Satish joined, and I think this has definitely grown from the very first meeting that we have, and so I'm really very happy to be here this morning to share some of what we are doing in Singapore. It's not just all about research, but I think many of this that I'm going to share are actually newer area of things that we are developing to try to make the treatment more accessible, because you have heard Dr. Satish tell you that actually there are many good drugs available and approved for the treatment of myeloma today, but they are all very expensive. And sometimes, they may not be immediately available after their approval in the US. So we have developed a strategy for us to get early access to these drugs for our patients, and better still, for free, in the context of doing it through a clinical trial, right? So at the same time of that happening, which is our patients getting the treatment and the drug, it also allows us to learn about how these drugs actually work and affect our Asian patients. Because don't forget, when these drugs are studied and approved, they are mainly studied in US, in Europe, with a Caucasian population. We sometimes don't fully understand what their effects are on Asian patients. And certainly in these trials, we have identified some side effects that are quite special and unique to Asian patients, right? So, by doing it in the clinical trial context, it allows us to get our patients treatment early, but also allow us to learn so that we can subsequently better optimize the treatment for our patient. So I think what our strategy is in Singapore is that we have looked at, this is by no means comprehensive because I don't want to overload everyone, but I think the key message is that we are actually doing a lot in different areas for our myeloma patient. Myeloma patient is not by far the most common cancer. It's in fact relatively rare, small population. The number of people working and treating myeloma patients in Singapore is also not big, but we are very close-knit and very united community. And I can see from the patient's response too that the patient population is becoming more aware of things that can be done for myeloma patients is coming together. So I think we have a very small and very close community. And because of that, we actually work together on many things. So we have strength and unity, and hence many things is happening for myeloma patients, which is only a good thing, because it means that hopefully many of these things will eventually benefit the patients clinically. So I'm just going to cover 4. The first one is that, as Dr. Satish have alluded to as well, is that we have been working on a treatment guideline for myeloma for Singapore, and this has just been published in the Singapore Medical Journal a couple of months back. This is something that we developed that is relevant to the local setting. And we hope that with this document, which is available to all the doctors in Singapore, it will, number one, raise awareness for the diagnosis of this condition, because GPs and so on read this journal article as well, so that they will be aware of what are the tests that they need to look at, what are the symptoms that they need to raise some alert to think of this diagnosis. It will also guide some of our physicians that are practicing not in the main hospitals, SGH and NUH, to know how to initiate treatment and so on, right? So that it's more standardized. You don't have this variation. It doesn't matter so much, where you go. Now, clearly, if you go to a private facility, they are not within our jurisdiction. So they may recommend slightly different things to you. But again, this document may allow you to then check and say that, hey, what they are offering kind of within what is generally recommended, or not. So I think this is a useful document. that has just come out, as you can see. And the authors are from all the main hospital in Singapore, Tan Tock Seng, NUH, and Sing Health that treat myeloma patients. So we have some patients from Tan Tock Seng as well, right? So if you're worried that why is Tan Tock Seng's doctor not here, it's not because we don't like them. It's just today they're a bit busy, but they are involved in the coming out with this guideline. So if you go to Tan Tock Seng and has treatment, pretty much they will start you on the same treatment. They won't veer too much from what is standard. So you don't have to worry if you're a Tan Tock Seng patient. You're in good hands there as well. The other thing that we have been trying to develop is better investigations, better tests, particularly tests that will allow us to look at where the myeloma is in the whole body. Okay, because very often when you have myeloma, you get a blood test, they tell you there's abnormal protein. Where is this abnormal protein coming from? We say that it's mostly from the bone marrow, so we check your bone marrow, we do a bone marrow test, and we send the cells for testing. But the bone marrow test is really taking the cells from one spot in the bone marrow. So if some patients come and ask me, is it affecting my brain? Is it affecting somewhere else? I can't really tell the patient, right? So we have some ways to image the patient by doing scans, right? We sometimes send some of you for PET CT scans to look for spots that light up in the body. We sometimes send you for X-ray, right? Sometimes we send you for MRI. It's like, why so many different tests, right? What are they, But the truth is that different tests actually provide different information, right, that may be useful. So what we have been trying to develop in Singapore is this special imaging test, which is a PET MRI. So it combines the best imaging that we have for myeloma into just one single setting. So you don't have to go for one test, another test. It's just one time you do it all. So this is currently a research that we are doing. We have tested this on about 6 patients before they started treatment and after they have treatment to see whether this will provide useful information for changes, to the lesions when they undergo treatment. And at the end of treatment, between those patients that still have abnormalities and those that don't have, does it make a difference to the outcome? So this is a test that we're developing. And so what you're seeing here is that this is an area in the chest cavity, and these are different sections. You can see in red here, this is a lesion that is present in the chest wall of this patient, and it's lighting up in bright colors, meaning that there is cancer activity in there, right? So this is one type of test that we are developing, and we hope that it will be better than the existing X-rays and different types of imaging that we have, because we can do them all in one setting. The other thing that we have established, and this is not just a Singapore only, but now it means that we can do this type of assay very robustly, is that we have developed or established this method of detecting very, very tiny amount of myeloma cells in the bone marrow. So very often in the past, we will just tell whether a patient is in complete remission by just doing a blood test and maybe checking the bone marrow and counting the cells that look like abnormal cells that is below a certain level. But we know that even at that type of level, many patients actually still have small amount of disease. We know that because almost all these patients eventually relapse or progress, meaning that there's still some abnormal cells in there, right? So we really need much more sensitive tests, meaning that tests that allow us to detect maybe 1 abnormal cells in 1 million cells, so very small amount. And those patients that we cannot detect anymore using these very good method is likely to have very long remission or cure. And certainly data from Europe and US are already suggesting that. So, we need better tests, right? So this test, which is called flow cytometry, and some of your doctors now may offer this to you, allow us to look, you see every single dot down here is one cell. So really, concurrently, you look at many different cells. And what we do is we stain the cells on the surface with different antibodies. So these are the X's, right? So together with this whole panel of antibodies, we can actually tell whether a cell is abnormal or normal, and we color them in different colors, right? So it's quite comprehensive. It allows us to differentiate normal from abnormal plasma cells, Because when you get treatment, more of the normal plasma cells will come out because they are normal in your bone marrow, but the abnormal plasma cells should all go away, right? And sometimes when we look, we can't tell whether they're normal or abnormal because they look the same. So this test will allow us to differentiate as well. And with this, actually, we are now doing some trials in Singapore together with Sing Health, Tan Tock Seng as well, to use this assay to see, Dr. Satish is leading one of these trials, whether we, in patients who achieve a negative disease state with this kind of assay, do they need to have more treatment or we can stop them earlier, right? So we can start to then answer this treatment to better rationalize who are the patients that need more treatment, who are the patients that can stop treatment earlier, like maintenance, the question of whether everyone needs to go on maintenance or not. So we are starting to ask those kinds of questions because we have the ability to do these tests in Singapore. Then I guess the other side that we're starting to try to do is that we want to understand a bit better what could be the cause of myeloma. I mean, a very common question that patients come to clinic and ask us is this a genetic problem? Will I pass it down to my children, or is it passed down to me by something? The other common question they ask is this in the food, something that I ate or something like that, right? So those are the two common things. I don't think it's related to the food, any particular food, but there has been some association between obesity and development of cancer, including myeloma. The risk is not high. It's not like if you are obese, you are 10 times more likely. It's probably like 1.5 times, so it's like 50, a bit more likely. And so, this war on diabetes thing that the government is doing will certainly help that, because I hope that in the future we'll have less obese people, more healthier people that will also reduce their cancer risk generally. That will also reduce the risk of myeloma. But that's an uncommon association. So what could be the cause of myeloma? Is it in the genes is what we are asking, okay? And we found an interesting association as we start to look at the incidence of myeloma in the different kind of population around the world, okay? So you can see here in amongst the African Americans, so these are the black Americans, right? The incidence is every 100,000 of the African Americans, 10 of them will get myeloma, or in fact close to 11, okay? Then you get the Caucasian and Hispanic, these are like people from Mexico and so on, it's half of that, okay, half of that. And then you look at Asian, okay, American, it's only 1/10 of that. So actually, the myeloma incidence in Asia is low. It's the lowest in the world, okay, amongst all these population. But Asia is one of the largest population in the world. We've occupied 60% of the entire global population. So although it's rare, it's very common if you count the numbers. We have more myeloma patients than the West altogether, okay? So it is still of interest for us to know, because what we find in our studies may help us to develop screening tests, where we can check the genes of people and find who are the people with the susceptibility gene. That means if they have this kind of gene, they are more likely to develop myeloma. Then we can set up surveillance for them earlier on, and we can detect the disease earlier and treat them earlier and potentially cure them, right? So this is what we aim to do. So this is just a map of the world that shows the same data. So we have started to collect samples from many myeloma patients. Sing Health is doing this, we are doing this. So this again is a study that the whole of Singapore is going to be doing together. We in Singapore have already done the sequencing of normal people in Singapore for quite some time, and we've built up a database of what is normal genetic looking like in a Chinese, in a Malay, in an Indian. Okay, so then from our myeloma patients, we can then compare to the normal people and see what are the things that are different. And then we can also compare with the data that has already been established in America between Asian and Americans. What are the difference? Why are Caucasian 2 times more than us? Then we can identify the critical genes that may be involved in the development of myeloma in our population. Right, so this is something that we have started. And this same exercise can also help us to identify why some patients in Asia have some unique side effects to drugs. Okay, and if we can identify some genetic factors that is associated with some of these very severe side effects, although rare, then actually that can come into the drug label as a prerequisite test before we start someone on that drug. Just like if someone is allergic to some antibiotics, we have some drugs now, not cancer drugs, that you require to do a genetic test before you start the treatment because they can cause very severe side effects for the patients. So this is what we hope from this type of studies. Then the other type of studies we want to understand is that we know that myeloma is actually more than one single disease, even in the same patient. So if this is patient A, when we do their bone marrow, it may look like all the cells are looking the same when they look down the microscope, right? But inside the cells, the genes that are affected are actually quite different, okay? So you have a few different genetic changes in the cells, and they're different. With treatment, many of them will be eradicated, as you can see here, right? Those in dotted line, they are all gone. But there may be still one or two types that is left behind. So what we wanted to do this is that we will be, and we have been, collecting patient samples at diagnosis, after they have received treatment, and we're doing sequencing studies to look at what are the genes of the cells that are still left behind. So why are they left behind? They're left behind because they are not responding to the treatment. So what is so special about these remaining cells that don't respond to treatment? So if we understand that, then in the future, potentially, at this stage, when we check your blood and you show that you have still got 20% of disease, can identify what is the problem in these cells and change the treatment to kill these remaining cells. Rather than now, essentially we are just giving everyone the same treatment and kind of hoping to see that people respond. And then when they don't respond, we kind of also give the best guess of what's the best next treatment to give. There's a lot of guessing around. Unfortunately, medicine is not as precise as we hope it to be, but we hope that with better understanding of the disease, better use of new technology, we can have better precision in the way we give treatment to the patient. So I say all that is to say that research is also very important for us to improve the way we can treat patients. So when your doctor in the clinic come and ask you, would you mind donating your bone marrow cells for some research when we do the bone marrow test anyway, I hope more of you after today will say yes than say no, because this may eventually help yourself. Because we never know, myeloma patients are living longer and longer, and towards the, after 8 years, say for example, when it comes to the time where we're running out of treatment, this research that we do now may actually well help you 8 years later. Of course, we donate not to purely just help ourselves, but what is more important is actually help all the myeloma patients that will come after us, right? So I think that's the one important message that I want to share. And then the last thing I want to say is the treatment part, which Dr. Satish have already said. I won't share any data except to tell you that having access to treatment really is very important for our myeloma patients today. This is what impacts all the patients today. All the things I've just mentioned may impact in the future, but this is what is important today. This is really the pattern of a typical myeloma, right? You come, you have active myeloma, you treat the disease go into remission after a few years, the disease come back again, you treat again, and very often they will respond again, but usually the response is not as good as the first time, doesn't last for as long, disease come back, you treat again, you may go down, but eventually you'll reach a point where the treatment is not really very effective because whatever is left there is now very resistant cells, right? And this will then lead to the end of the patient eventually. And we also know from previous study that if a patient have failed a PI and an IMiD, so this term you should be familiar now after Satish's talk. So a PI would be, for example, like a Velcade. IMiD would be like either a lenalidomide or thalidomide. If you fail these two and you have subsequent treatment, the subsequent treatment ain't very effective. So 50% of the patients only have treatment that is effective for up to 6 months. And in fact, they survive on average only about a year. So this is after the IMiD and proteasome inhibitor. So it doesn't look very good. But since that data, we have had, and this one Satish have shown also, we have had a number of drugs that has been approved in the world. And I would say that for the last year or so, all of these drugs were available to our Singapore patients except for this elotuzumab, right? So these we can get hold of them actually if we want, but they are very expensive. We're talking about, on average, a month of treatment on these drugs is $10,000 or above, okay? Who in Singapore can afford, except you have health insurance or you're mega rich, right? So a small percentage only can afford this. But yet having access to these drugs are important because, for those patients that have access to these drugs, they survive longer than those that don't have access. And it's logical, because if you don't have access, it means that after you fail those two, you're pretty much end of the line. You don't have good treatment to give already. But if you have access to these new drugs, you can treat again, and then you can treat again, you can treat a few more lines, and they survive longer. So this is based on our data in NUH, and I'm sure in SingHealth is the same. So this means that for Singapore, I cannot say the same for others, but I pretty much think that this is universal. For Singapore at least, the access to these new drugs does make a difference to our patient. But how to get access to these new drugs? I mean, our only platform in the past is to buy the drugs, right? And they are so expensive, not everyone can pay and buy these drugs. So, learning from experience overseas, really one of the good mechanisms to get access to these drugs is through clinical trials. And clinical trials is not the same as what we always think of as experimental treatment. We are not, I still have patients who come there, are you treating me as a laboratory mice there? I don't want this, this is not. But it's not really the same. There are many types of clinical trials. Certainly some types are like that. But actually those tend to be what we call normal volunteer trials, where you are actually a normal person, and they have these different studies where they are really testing new drugs, and they want to test what kind of side effects these new drugs may have in a person, in a human being. And actually, usually those trials, they pay the volunteer quite a fair bit of money. In fact, I would also say that there are professional people in Singapore that actually just look for these kind of advertisement to go and volunteer, because that's how they earn the money, to pay cash. So it's not those kind of studies. In cancer, generally the trials are testing drugs that are already fairly well tested in the America or in the US. Sometimes it is true they are very new, but usually in the setting of patients that don't have much treatment choice. So you have to make a decision. It's like, I have no better treatment, so there's this new drug that is available to me. Maybe I should give it a try if I still want to see whether I can live a bit longer or not. But in myeloma, our strategy is not those kind generally. What we want to bring the trials are the type of trials that uses these drugs, like the daratumumab, like the carfilzomib, these new expensive drugs that has been approved in America and the US, and bring them here for patients in Asia. So, but it's not easy, and Dr. Satish will tell you that as Singapore, as SingHealth, as NUH, or even as whole of Singapore, if we're going to approach Janssen and say that we want to do a trial with daratumumab, they will say that, why should I do this trial in Singapore? How many patients do you have a year? I'd rather do it in Korea. Maybe there's more patients there. It's a bigger market for us. It makes more sense. Are you asking some interesting question of the drugs? And very often, there's so many trials that there are no interesting questions left to ask, right? So it's very difficult to get them. So we decided to pool together investigators from key Asian countries, and this I must acknowledge the kind of efforts of the International Myeloma Foundation, which is a charity based in the US that really focus on helping myeloma patients in the world, and they see a need in Asia. Okay, and so through their effort, and Brian Dury is a very senior member in the community of myeloma physicians and experts that brought these different experts from these different countries together, Singapore, Thailand, Hong Kong, Taiwan, China, Korea, and Japan. And we did some studies, looking at what is the incidence of myeloma and so on, and that kind of data actually contributed to our knowledge that in Asia, myeloma is actually quite low in incidence. Okay, and after that, the next step really was to develop this platform, this clinical trial network for us to do trials, so that we are in a stronger position to go to the pharma company and say that now this is a pan-Asian trial. This is a big market for you. It's important for us to get this information in Asian. Some of our information may even help you to get approval of the drug in some of the Chinese countries like Taiwan or China, potentially, right? So it becomes much more attractive to them rather than the small little thing that they couldn't get good information from. So we developed this, and it's not easy. It took us about 2 years to set up all the mechanism for contracting and all those things. And our objective is really to get early access to good treatment for our patient, establish Asian data because there are some unique side effects potentially, and we don't know if they work in the Caucasian, whether it work in us or not. And study combinations that are relevant to Asia. I think this is also very important because many of the combination study that Satish talked about that is done in the US and Europe, they're combining 2 or 3 of these very expensive drugs, which is, when I say that each drug costs 10,000 a month today, you can imagine if you combine 2 or 3, each month is going to be 30, 40,000 of treatment. That's even more impossible. So yes, although they show all these nice data, I don't know how to apply that in my setting because no patient is going to be able to get those combination. So what we wanted to study was combinations using this new drug with just one new drug and then 2 other drugs that are cheap that we already use, right? So this makes it more likely that we can use these combinations in Singapore. And we want to elevate our standing so that we can become a good partner to industry for doing trials and bringing these new drugs to Asia, particularly in this kind of setting. And so we were successful in establishing all those and activating our first study in December 2014 using pomalidomide, and we have patients here in this audience that were enrolled in that trial. I would say that it was very successful because in about 2 years, we recruited 136 patients in Asia, so showing that we can actually recruit many patients in Asia. It doesn't take years to do that, right? And this data was reported in the biggest hematology meeting in the world, the American Society of Hematology, in December 2016. And the results are very good because in this study we have, and this is our study over here, the results, we can see that the response rate, which is this row, we see 50% of these patients responding. And the patients coming into the trial are those that have failed the proteasome inhibitor and the IMiDs. Not a lot of treatment, good treatment options left after that. 50% of them responded, okay? And compared to other studies around the world, right, looking at the PD column, we are, in fact, a bit better than them. About close to 10% of them get a very deep response, okay, VGPR or more, with a few complete response. The progression-free survival is almost double that, and our overall survival is 14 months, right? So very good, meaning that half of the patients survive for more than a year after that. And we have patients in this audience that is on this treatment for almost 2 years. That means they started right at the beginning and they're still taking it now, okay? And the good thing is the side effects is very low. So we know now from this study that this drug is good for Asian patients. They're well tolerated. It's an oral treatment. They just take tablets all the time. It is effective, in some patients. We also learned something new is that for those that didn't respond very well to just the pomalidomide and DAX, if we add cyclophosphamide, we can actually increase the response for some of these patients. So we also found a way to optimize the usage so that we don't give everyone all the drugs at the beginning, but those that don't do that well, we can add a drug, right? So we learned something from here. Patients benefit, and we get access to this drug that costs $10,000 a month. So, and the patients don't have to pay for the drugs on this trial. So I think it benefits everyone. This is the kind of win-win situation we try to achieve with this. And as a result of that, a few things have happened. One is the pharma now know that we can do this. And we have Amgen that has carfilzomib willing to partner with us. Celgene with the pomalidomide is doing another trial with us where we randomize and we compare which is a better treatment. We have daratumumab, the monoclonal antibodies that Satish mentioned from Janssen. They are partnering with us. And we're looking at some other drugs as well. And Satish is developing this, which is going to be approved, in fact, already, and it's going to come up. So this slide is a few months back. And so our strategy is that now we have an opportunity to do a trial with each and every one of these new drugs to ensure that our patients have access to every single one of these drugs, at no cost, at least for the duration of these trials. We are also developing, as you can see in this column, trials that will be suitable for patients at every phase of their disease, when they have relapse, when they have newly diagnosed disease, when they have high-risk disease, when they have low-risk disease, looking at maintenance, looking at things, because every step of the treatment is a cost, and is a big cost. And if we can kind of reduce the cost to our patient at any step of the way, it will be a big help, actually, for them to have as much treatment as they can get, or so that they have the finances to prepare themselves for all the subsequent treatment. So this is the trial strategy that we have in Asia. It's not just trials through this AMN. Of course, there are other opportunities where we do smaller trials on our own, and Dr. Satish has a few of these happening as well. But I think we are relying on as many mechanisms as we can to get these drugs in for our patient. Right? So I think that is something that will greatly benefit to our patient. And so again, if we talk to you about clinical trial, at least be a bit more open, listen first. We often don't rush you. We don't say sign now. No, we will explain to you. We'll give you the form. You can go back and read about it. You can ask us more questions. Once it's decided, then we get things started. So just be aware of these developments. So I think for the Asian Myeloma Network, our future is to expand more countries, more hospitals from the participating countries, but also start to look at these questions that we have as we practice, right? Should we give different treatment for the different risk group of patients? So Dr. Satish mentioned some patients have very high-risk disease because you have bad genetics. And these patients, on average, even with all the best treatment now, are living for about 2 to 3 years. Not very good. So should we just keep giving the same treatment as we're giving now, or should we think of different ways to treat them? And we can test that through the clinical trials, right? And then things like based on response. So if you have a complete response or a response that is non-detectable by this sensitive method of the flow cytometry, maybe we can stop treatment for them earlier. Do they need to keep having the treatment? So these things, again, we can test and see. And once we have finished this work, then in the future we'll be better able to treat our patients in a more rational manner. And the last slide I want to show is another strategy that we are trying to do at least at NUH, and we'll get our colleagues in SingHealth to work with us on this, is that for many of the disease, there may be not very good way to target the tumor cells from inside. So we can bomb them from the outside in that sense. And how do we do that is that we discover what are the proteins that are expressed on the cell, and we develop an antibody that can attack or target that protein. So some of these things like daratumumab, which is already approved now, is the same kind of drug or of this antibody. But we are developing this to focus particularly on the high-risk disease, which I said, currently is still not doing very well. So we're looking at, for these high-risk disease, the myeloma cells, what are the proteins they express? We are going to develop an antibody. And then once we have a good antibody, it opens up to these different, what we call immunotherapy platforms that we can transform this antibody to a better kind of magic bullet, if you want, right? Either using CAR T cells, using it as a way to deliver genetic treatment, to deliver drugs into the cells, and so on, right? So this is a very exciting kind of next step of treatment development that we are doing in Singapore. And some of these products, hopefully, we'll see in clinical trial testing in the next 3 to 4 years. This is not the short term. Okay, slightly middle term, but at least we're heading in that direction. So hopefully, again, this type of work will bring some new treatment possibilities to our patient in the coming years. So I think with that, I thank you very much for your attention.